Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Sarah Anderson. During this podcast, Dr. Nancy Reau, Professor of Medicine and Chief in the section of Hepatology, Associate Director in Solid Organ Transplantation, and Richard B. Capps Chair of Hepatology at Rush University Medical Center in Chicago, Illinois, discusses new viral hepatitis data, including studies related to hepatitis B, new therapies and therapeutic vaccinations, emerging treatments for hepatitis delta, and hepatitis C care cascade and considerations for monitoring after HCV cure, which were presented at EASL's International Liver Congress, or ILC 2022. For more information about Dr. Reau and for a link to the full online educational program, including downloadable slides, please visit the link in the show notes for this episode. Now, let's get started and hear what Dr. Reau has to say about new viral hepatitis data from ILC 2022.
Hi, I'm Nancy Reau from Rush University Medical Center, and I'm really excited to communicate some of my thoughts after ILC 2022 around viral hepatitis. So I wanted to hit hepatitis B and D first. And I think that one of the most important things is that clinicians and patients are both hoping that we can see the same explosion in antivirals that's going to allow for this high efficacy short-term cure for hepatitis B. And although the antiviral therapy in phase 2 coming out of ILC 2022 is really exciting, it's not that explosion that we saw for hepatitis C a few years ago. Now, for context, it did take hepatitis C a long time before they could get a curative short duration therapy. And these are very different mechanistically viruses. But I think, number one, do not abandon hope on hepatitis B. There were a number of compounds that looked very attractive. The siRNAs are decreasing hepatitis B surface antigen. There was a new polymerase inhibitor that showed this essentially virtually no risk of flare when it was discontinued. The NAPS and the CAM therapy, these are all new mechanisms and are really attractive as combination therapies. And so I think that the most important thing is that many of the compounds that we saw for B had safety and efficacy that allows them to progress to phase 3 trials or bigger study. And that's really exciting for patients and providers. And we don't want to lose that vision that drug development for something that's safe and efficacious is slow. And we are seeing this definitely move in the right direction. For Delta or hepatitis D, I think that we continue to get more and more data showing that bulevirtide, which is soon to be approved, hopefully in the US, and is on conditional access in many parts of the other world, continues to show good efficacy and safety. It shows good antiviral effect, which seems to be cumulative, and we are moving beyond that 6-month and 12-month duration. And there are signals that it is improving things like fibrosis markers, stiffness markers. Maybe hopefully this will translate into a reduction in clinical events in the long term. So I think bulevirtide still is very attractive. And anytime we see something in the hepatitis B pipeline that might affect surface antigen or eliminate hepatitis B, you know that that's ultimately going to translate towards Delta. Got a little bit of data on lonafarnib and on Lambda, so that there is more in the pipeline than just bulevirtide for Delta also. So it's really important to remember that hepatitis B is a vaccine preventable virus. And so we know that hepatitis B surface antigen prevalence in 5-year-olds is our metric that really shows that we're doing a good job with vaccination strategies. And so do not forget to vaccinate. The CDC has made a push to simplify vaccine, requirements or vaccine indications. And so that rather than some complex structure that's based on risk, we really in the US are pushing towards universal vaccination with catch-up in pretty much all adults. There is a difference, though, between a therapeutic vaccine and a vaccine that's meant to, prevent infection. And ILC 2022 did show some really exciting therapeutic vaccines. Now, our therapeutic vaccines are either meant to augment immune recognition. And remember, when we're talking about hepatitis B and curative or functional cure, there's not just an antiviral strategy, but there's also an immune modulatory strategy. And some people think that you're going to need a combination of antiviral agents as well as immune augmentation. And a lot of these therapeutic vaccines are doing both. They're triggering that immune recognition so that you can get over that immune tolerance that we think helps allow hepatitis B persistence. And then the last thing, I'll turn to hepatitis C. I think that we forget that hepatitis C is not cured, even though worldwide this is still a virus with significant morbidity and mortality. We do have excellent therapy, but the Congress reminded us that the care cascade is still, falling apart in multiple places. So we still are lacking in screening, lacking in linkage to care. Once you get that person on treatment, then efficacy is excellent, and we expect that person to be cured. However, we have a lot of gaps in the steps before engaging in treatment. There were also a number of abstracts that look at how to assess a patient after cure. This is really, really important. Our patients want to be cured, and then they want to pretend like they didn't have, hepatitis C. And there were a number of abstracts that reminded us that they continue to have that residual risk, especially for liver cancer. Cancer rates increase over time, although curative therapy decreases monumentally the risk of liver cancer in the long run. There is a slight incremental tick after cure with each subsequent year. And so we want to make sure that we appropriately identify the patients that need to continue in these screening programs and engage them in this longitudinal surveillance. I don't think we have a perfect model yet that would allow us to identify a patient at low risk that has cirrhosis. But any patient who's got advanced fibrosis really needs to be engaged in longitudinal care, because hepatitis C continues to drive liver cancer rates, along with hepatitis B and D. And we want to make sure we do not miss early identification of these patients. As our hepatocellular carcinoma treatments have incredibly improved, they are best for those that are found at early stages and not late stages.
Thank you very much to Dr. Reau, and thank you to our listeners for joining in. As a reminder, to view the full conference coverage program of EASL's 2022 International Liver Congress on the Clinical Care Options website, click on the link in the show notes for this episode. And please be sure to check back regularly for more episodes on important infectious disease topics. Thank you.